I'm presenting perceptions of older adults and health professionals about digital health tools for elder mistreatment screening. And I just want to acknowledge the full team for this work. We're supported by a grant from the NIH, and we have no relevant commercial financial relationships to report. For some background, elder mistreatment includes physical abuse, financial exploitation, emotional abuse, sexual abuse, neglect, and abandonment. As many as 1 in 4 older adults experience mistreatment at some point in their lives, and we have a great opportunity in the emergency department because 22% of US adults 65 or older visit us each year. Our current approaches for identifying elder mistreatment are inconsistent and often ineffective. So the objectives of this study were to obtain the perspectives of older adults, caregivers, and emergency care providers about screening and interventions for elder mistreatment in the ED, focusing particularly on digital health tools. We conducted 3 in-person focus groups with a total N of 31 with older adults from the community, caregivers for older adults, and clinicians and social workers who worked in the emergency department. These were semi-structured interviews with a guide that explored attitudes about the process of divulging abuse, attitudes towards the emergency department as a location for screening and information delivery, and perceptions of digital tools for screening and information. Interviews were transcribed and double-coded. We developed an initial thematic framework by summarizing codes by major themes and sub-themes, and then collaboratively as a group decided on final thematic framework and selected illustrative quotes representing a range of responses relevant to each theme. We in total recruited 24 older adult community members, 83% were female, 50% Black, and 4% Hispanic or Latino. We also included in the first focus group 3 social workers, 2 ED physicians, and 2 caregivers. Here's what we found. The first theme really was around the challenges to disclosure of mistreatment. These included for our participants feelings of vulnerability, concerns about losing their homes, social supports, and connection to caregivers, and uncertainty about what happens after disclosure. One community participant said, I think also many of us when we're older, we don't have the deep connection and the feeling of the love and warmth around us, connections with family and friends. I think we lose a sense of worthiness, a sense of feeling important. An ED social worker said, you also have to respect the fact if my caregiver is the one who's abusing me financially or physically, and that happens to be my daughter or my son, there's an emotional attachment. A community participant said, I think many of them would say, what are they going to do about this anyway? Why am I answering this? And another community participant said, I would be hesitating to answer for fear that the unknown, that something terrible is going to happen here. So maybe I need to keep that to myself. The second theme regarded ED-specific barriers to disclosure. One ED physician said, a lot of times I feel like, especially in emergency departments, we're trying to move quickly. There's routine checklist. Do you feel safe at home? Do you have this? Do you have that? That's not a real conversation. A community participant said, if somebody's in an emergency room, first of all, it's not a very pleasant place to be. When we asked about digital health tools for screening for elder mistreatment, the attitudes were generally positive, but they also acknowledged that some of the older patients may need assistance with digital health tools, and also encouraged us to retain a human element. One community participant said, I know people who stay in the house where there's mental, physical abuse. The computer is what they're on all the time because it's something to concentrate, something to do. They have nobody else to talk to, and that gives them comfort. Another said, if I'm not savvy with computers and stuff, it's harder on me. An ED physician said, I think you would still have to have someone on the ground though. So I think of my mom, she would be like, how do I do this? I don't know. What's this thing say? What does this pop up? The next theme was about recommendations from the participants for successful screening and interventions for elder mistreatment. And they included the need for education about neglect and abuse, setting the scene for this conversation, and providing empathy, including to the abusive person. An ED physician said, really sitting down, nice quiet environment, not in the hallway, making sure the patient is comfortable in terms of food, water, music, whatnot, and saying, hey, I'd like to broach a difficult subject with you. I know you might not want to share right now. Can I talk to you about some of the concerns I'm having? A caregiver of an older person said, "Do you think they all understand what neglect is? Because neglect is such a thing. If you're in a situation and it's getting worse and worse and worse, you sort of lose your perspective of, am I being neglected, or is this what I deserve?" A community participant said, "Well, I would say it doesn't mean you don't love them. It doesn't mean that you're a bad parent or a loved one. It's help to both of you. You'll both grow through this if you permit someone to enter your world and help you through this hard time." So in conclusion, we found multiple challenges to elder mistreatment screening in the ED were identified by focus group participants. Empathy towards the abuser and better understanding uncertainty were identified as areas for potential development. Participants did respond generally positively to digital health tools and had recommendations for optimizing screening and interventions that we could use as we developed our digital health screener. We did feel that there was a need for further exploration of online only versus person-assisted screening for those experiencing mistreatment, and also acknowledge the need for development of programs with broad generalizability across diverse patient populations in the future. Thank you.
My name is Alan Zhang, and I am currently a fourth-year medical student at the University of South Florida Health Morsani College of Medicine. And I will be presenting an lightning oral abstract titled "The Falls Efficacy Scale and Vulnerable Elder Survey as Predictors of Mechanical Falls in the Elderly." And on this slide, I have listed all of our team members, including our principal investigator, Dr. Greenberg, and our affiliations, such as the Department of Emergency and Hospital Medicine, the Department of Surgery at the Lehigh Valley Health Network, and the University of South Florida Health Morsani College of Medicine. And this study was funded in part by an unrestricted community grant from the Anne and Carl Anderson Trust. And I have no financial disclosure or conflicts of interest with the material presented today. So on this slide, we have the study objectives, and some brief background on this study are that the CDC reports that amongst older adults, falls are the leading cause of injury-related death. And some staggering statistics are that in 2014, there were roughly 2.8 million older adults who had suffered from a fall, and of those, 800,000 were later hospitalized. And in 2015, the total cost on a healthcare system was roughly $50 billion just from falls alone. And the Falls Efficacy Scale and the Vulnerable Elders Survey are currently validated screening tools used to assess concern of falling, health deterioration, and functional decline. And our goal was to determine if the FES or the VES 13 could serve as a predictor of falls amongst older adults in the emergency department setting. Our study was a prospective pilot cohort study that was conducted at a level 1 trauma center at the Lehigh Valley Health Network Cedar Crest Hospital Emergency Department. And our inclusion criteria were emergency department patients aged at least 65 who are eligible if they had mechanical fall risk defined by CDC criteria, which were having fallen in the past year, having regular worry about falling, and feeling unsteady when walking or standing. Also, the subjects had to be English speaking and had to be discharged from the emergency department to home. And consistent with the tool's recommendation, the VES score of at least 3 was considered a positive screening score. And for the FES, each of the questions was rated on a 4-point scale from not at all concerned to very concerned, and the subjects were asked to rate their concern about performing various activities. And the total score ranged from 7 to 28, 28 being very concerning for falls and also functional decline. And the participants were then followed by phone, and the results of the 1-year follow-up self-report of the falls history were described in our results. And on the right-hand side, you can see our concert flow diagram. and we enrolled a total of 200 subjects, and a total of 16 were excluded from analysis. And we were left with a total of 184, which we then analyzed. And what we found was there was not a significant difference in the proportion of falls reported by males as compared to females, and the proportion of those with the BES13 score of at least 3 did not also differ between the sexes. However, interestingly, amongst males, the predicted risk of fall when the reported BES13 increased remained at a roughly around 18, while there was an increase from around 12 to 40% amongst females. The overall anticipated outcomes of the project were that there was not a significant difference in the rates of falls based on the BES13 score. And also the FES score would also likely not provide much predictive value into fall rates because the score did not statistically differ from comparing subjects who had fallen versus those who did not fall. However, there may likely still be sex-specific differences between utilizing the bedside decision aid tool and the selection management options, which could contribute to the rate of falls. And this study also has a limitation in that it may lack generalizability because it is a single site study, which only included patients who spoke English and were discharged home from the ED. In conclusion, the subjects who had a BES13 score of at least 3 were statistically no more likely to have fallen than those who did not. And also the FES score did not statistically differ from comparing those who had fallen versus those who did not. So we would have to contemplate further and consider alternative screening methods in the ED setting for fall risk. And thank you. And does anyone in the audience have any questions?
Hello, and thank you for joining me as I present our initiative to deprescribe inappropriate medications from the emergency department for older adults after falls. My name is Catherine Selman. I'm currently a geriatric emergency medicine fellow at University of North Carolina at Chapel Hill. I'd also like to acknowledge and thank my co-authors and co-contributors who have worked so hard on this project. As a disclosure, we did receive funding from the Carolina Geriatric Workforce Enhancement Program. In the United States, over 35 million falls occur in older adults every year, resulting in more than 8 million fall-related injuries and contributing to morbidity and mortality in geriatric patients. While medications are known to be a modifiable risk factor for falls, the prevalence of older adults taking fall risk increasing drugs is still well over 50%. The emergency department is a unique setting to intervene immediately on patients who have fallen, particularly in patients who are able to be discharged. The purpose of our initiative was to implement an ED-based model of medication reconciliation and patient education for patients who present after a fall in order to decrease the risk of future falls. This was a prospective single-center study done at an academic emergency department that serves over 65,000 patients every year. From August 2020 to July 2021, adults 65 years and older presenting with the chief complaint of fall were enrolled. They were approached by a pharmacist and a medication reconciliation was performed, reviewing both the patient's prescribed and over-the-counter medications, and identifying those on the CDC's list of medications that may increase the risk of fall. Our pharmacists then provided direct education to patients about these medications and how they may increase the risk of fall. They made recommendations of tapering, stopping, or discussing further with their primary care doctor. These recommendations were shared with the emergency department provider, summarized in the chart provided in the discharge instructions, and as shared with the patient's primary care doctor as well. At 3 months and 6 months, we reviewed the electronic health record to determine the number of fall-related return ED visits and to determine if the recommended changes had been implemented. From August 4th to December 20th, 2020, medications were reviewed for 187 adults aged 65 and older. The average age was 80 years old, 65% are female, and 83% were white. On average, patients were taking a total of 11 scheduled medications, and an average of one of these medications per patient was flagged as high risk. The most number of flagged medications for one patient was 8. The most common flagged medication classes were, in order, anticoagulants and antiplatelets, antidepressants, and anticonvulsants, which included gabapentin. Opioids and benzodiazepines were the 4th and 5th most common medication classes, respectively. Out of the 187 enrolled patients, 110 patients received medication recommendations from our pharmacists. At the 3 months, 8 patients had repeat visits for falls. 5 out of the 8 patients had received medication recommendations at their initial visit. Our results at 6 months in the final analysis are still in process. While our final analysis is still pending, this is a promising start to show that an ED-based pharmacist-led model to decrease high-risk medication usage is practical and feasible intervention to address modifiable risk factors for older adults who are at risk for falls. Thank you, and I'll now answer any questions.
Good afternoon. I'm Tom Ringer. I'm an emergency physician at Sinai Health System and the University Health Network, both in Toronto, Canada. And today I'm pleased to present the results of our study titled Use of the Canadian Triage Acuity Scale Frailty Modifier in Older Adults Attending 2 Urban Canadian Academic Emergency Departments. We have no disclosures. I'd like to acknowledge the work of my co-investigators as well as our research assistant, Tammy Orascanin. Frailty is a multifactorial state of vulnerability that primarily affects older adults and predisposes them to a number of adverse outcomes in the emergency department, including mortality, adverse discharge such as long-term care, and ED reattendance, although there's presently no criterion standard for defining frailty in the emergency department. In Canada, the acuity of patients arriving at the emergency department is evaluated using the Canadian Triage Acuity Scale, or CTAS, which rates patients on a scale from 1 to 5, with 1 being patients who require immediate resuscitation and 5 for patients with minor complaints. In 2016, the ECTAS group allowed a new frailty modifier to allow triage personnel to up triage a patient who would otherwise be 4 or 5 to a level 3 on the basis of a frailty modifier. There were no specific guidelines given for the application of the frailty modifier, but recommendations included functional impairment and age older than 80. The ECTAS frailty modifier was implemented at 2 academic teaching hospitals in Hamilton, Ontario in March of 2019. This implementation was not accompanied by any training or specific guideline or screening instrument. The objectives of our study set in these 2 emergency departments, therefore, was to look at patterns of use of the frailty modifier and identify the characteristics of older ED patients who were assigned a frailty modifier. We conducted a retrospective analysis of data collected from the EMR, Meditech, and the ECTAS dashboard involving patients age 65 or older at both sites between August 2019 and March 2020, since that was the earliest available data. Our study included 9,520 patients who were CTAS-3, either through the door or after application of a frailty modifier. The mean age and percent female are displayed here. Mean number of comorbidities was 3.4, and just under 16% of patients aged 65 or older received a frailty modifier. We noted significant variation in use of the frailty modifier by individual RNs, with some applying it to as few as 0% of patients, and some applying it to 39% of patients that they assessed, with quite an uneven distribution, as this histogram demonstrates. We then performed an analysis of difference of means using independent samples t-tests to compare the frailty modifier group and the non-frailty modifier group. We noted small but significant differences in age and number of comorbidities. Perhaps the most striking finding was the difference in use between Site A and Site B. At Site B, 39% of patients received a frailty modifier, whereas only 18% did at Site A. One of the largest differences between the frailty modifier and non-frailty modifier group was in arrival by EMS, with a mean difference of 14.4% with a relatively narrow confidence interval. So a 15% absolute increase in arrival by EMS in the frailty modifier group. There were no significant differences in gender as reported at triage, nor in admission or death in department. Out of 9,520 patients, 5 passed away, only one of whom was a frailty modifier patient. And after hours arrival did not differ between the two groups. To summarize, we found a wide variation in use of the ECTS frailty modifier between individual RNs, and a very significant variation between the two sites, with it being applied more than twice as often at one site. Frail patients were more likely to have arrived by EMS, were somewhat older, and had slightly more comorbidities. They were not more likely to be admitted, and they were not more likely to pass away in the department. Our study has a number of limitations worth noting. Significantly, it's retrospective and observational, which can introduce the risk of bias in interpretation. It has a limited number of variables. We are limited to the quality and reliability of the data in the EMR. It is impossible to know whether a triage RN considered applying a frailty modifier and didn't use it or forgot to consider it altogether. And we do not know the impact of COVID-19, how that might affect generalizability. To conclude, it appears that the implementation of triage frailty screening without guidelines can result in wide variation in frequencies between raters and sites, and that arrival by EMS appears to play a large role in whether a patient is considered frail. Ours is the first study to look at the use of the frailty modifier whatsoever, and the finding about EMS and its relationship to frailty is a novel finding as far as we're aware. Future research should look at the relationship between the frailty modifier and patient-oriented outcomes, should try and reproduce these results at other CTAS sites, should investigate the reasons for the use and non-use of the frailty modifier by individual RNs, and implementing a quality improvement initiative to improve frailty screening. Thank you for the opportunity to present the results of the study, and I look forward to taking your questions.
Hello, my name is Nicholas Suhueta, and I'm a second-year medical student with the FAU College of Medicine, and this is my presentation regarding the characteristics of geriatric head trauma patients who do not receive head CT imaging. This was done in special conjunction with the emergency department of the FAU College of Medicine, and I want to thank the contributors to this project, those being Dr. Scott M. Alter, Dr. Joshua J. Solano, Dr. Lisa M. Clayton, Dr. Patrick G. Hughes, and Dr. Richard D. Shee. This presentation and research was funded by a grant from the Florida Medical Malpractice Joint Underwriting Association. The authors have no conflict of interest. Head trauma is a leading cause of emergency department visits in the United States among geriatric patients. It actually leads to double the rate of hospitalizations for non-fatal head injuries for geriatric patients, and around 80,000 visits to the ED annually. Due to an increased risk of intracranial hemorrhage, a majority of older patients presenting with head injury receive CT imaging. This is in part due to new guidelines like the Canadian Head CT Rule and the New Orleans Guidelines, listing old age as a risk factor in developing intracranial abnormalities that might need a neurosurgical intervention for better outcomes. There is a lack of literature characterizing geriatric patients with head injuries who do not receive head CT imaging, and geriatric patients tend to be excluded from many studies who test the efficacy of these new guidelines, making for a little bit of a blind spot when it comes to geriatric patients. Detailing these characteristics of patients who do not receive head CT images in future studies and analyzing their outcomes could be the first step in better optimizing patient care for geriatric patients with head injury in the future. This study aims to characterize the signs and symptoms of geriatric patients with head injuries who do not receive head CT images during their head injury-related ED visits. This was a prospective observational study of geriatric patients who presented with a head injury to the EDs of 2 level 1 trauma centers in South Florida. Patients aged 65 and older who sustained blood head injuries were included. Patients who sustained penetrating head trauma or were transferred from another facility or had an injury greater than 24 hours prior were excluded. Head CT imaging was ordered at the discretion of the treating physician who was not directly involved in the study. Patients were grouped by whether or not they had a head CT performed. Presence of specific signs and symptoms were compared between those with the head CT and those without, using chi-squared and odds ratios. Patient data was extracted from patient charts, and those signs and symptoms included loss of consciousness, altered mental status, headache, seizure, nausea, vomiting, and dizziness. The signs included were visual physical signs of head trauma, laceration, hematoma, abrasion, raccoon eyes, which is also known as periorbital ecchymosis, Hemotympanum, battle sign, and neurologic findings were included as relevant. In the study, 4,242 patients were included. 4,210 patients had CT imaging, and 32 patients did not have head CT imaging. Patients who had a head CT performed actually had higher rates of signs of head trauma, 63.5%, than those who did not have head CT performed, 37.9%. The yes and no portions of the chart detail whether or not the patient received a head CT, and the rows, all of the patients in the row did have that symptom or sign. So for example, 784 patients had loss of consciousness out of the 4,210 who received a head CT. So 29% of those with a head CT had loss of consciousness. For the second line, for the no portion, 5 out of the 32 had loss of consciousness and did not receive a head CT. So for the most significant line, we see that signs of head trauma, 2,364 patients had physical visual signs of head trauma and did receive a head CT, and 11 patients had signs of head trauma, only 37.9%, and did not receive a head CT. So we can see a significant difference in patients who had signs of physical head trauma. No other significant differences in head CT performance were found for any other sign or symptom. Patients with any signs of head trauma were more likely to have a head CT performed than patients without any signs of head trauma. No symptoms, including loss of consciousness, altered mental status, headache, seizure, nausea, vomiting, and dizziness, had an association with rate of head CT performance. No individual signs such as laceration, hematoma, abrasion, periorbital ecchymosis, battle sign, or abnormal neurologic findings had an association with head CT performance. The only sign that did was signs of physical visual head trauma. Future research should examine other differences between those who receive CT imaging and those who do not, as well as examine their outcomes. And some of these outcomes can examine repeat ED visits within a short time frame for the same symptoms, mortality, length of stay after first visit, and neurosurgical intervention. Thank you very much for listening to my presentation, and I hope you have a great day.
Hello, my name is Rachel Wu, and I am an undergraduate at the University of Pennsylvania. I'm here to talk to you today about our work on the evaluation, management, and disposition of abdominal pain in older adults presenting to the emergency department. I'd like to thank my team at Penn. This is definitely a group effort. We have no financial COIs to disclose. So why older adults and why abdominal pain? Older adults, considered 65 years old and older, comprise of 20% of all emergency department visits and 36% of hospitalizations. Abdominal pain is the #1 chief complaint among older adults, and 1.4 million visits are made to the emergency department for this reason per year. It's highlighted in the literature as a high-risk condition for older patients. One study found that 5.3% of abdominal patients died within 60 days, and 8.3% left with a new chronic disability. Treatment of older patients presents additional problems and warrants special caution. They display atypical symptoms and have underlying causes of abdominal pain that are unusual for most younger adults, for example, mesenteric ischemia and abdominal aortic aneurysms, or AAAs. The top cause of death for discharged Medicare patients with a chief complaint of abdominal pain was cardiac ischemia, which is a diagnosis typically associated with chest pain and non-abdominal pain. So physicians are less likely to suspect it within older patients with abdominal pain. So overall, it's a high mortality, high morbidity, yet we see significant practice variations. So we wanted to know, are these patients receiving the appropriate care? So we wanted to characterize and evaluate the variability within this demographic. We used 5 years worth of data from NAHAMSIS, 2013 to 2017, and we analyzed 82,000 visits to 1,200 emergency departments within the US, which projects to roughly 532 million emergency department visits after survey weighting. We included anyone whose chart said they were 65 years old or older, and we excluded patients triaged to an ESI 1 or the most severe triage level, as the acuity of these patients often hinders the reliable ascertainment of a chief complaint, which was our principal criteria for data selection. So in table 1, we evaluated the characteristics of emergency department visits for patients over 65 years old. In the right-hand column, we have older patients who presented with a chief complaint of abdominal pain. In the left-hand column, we have patients who presented with any other chief complaint. When we examined the proportion of patients who were categorized in the ESI2 triage level, which we considered the highest level, given that we excluded ESI1, we discovered that abdominal pain patients were triaged to ESI2 at half the rate of their counterparts. So we're looking here. This is particularly interesting because abdominal pain patients were admitted to surgery at 4.5 times the rate of non-abdominal pain patients, indicating that although abdominal pain patients were considered at lower risk, they require more aggressive and invasive care to return them to stable health. This suggests that there may be under-triaging among older adults with abdominal pain. In table 2, we have the same columns, but here we're looking at the the management practice patterns. We have abdominal CT scans here, which are known to be highly effective testing tools for diagnosing the root cause of a patient's abdominal pain. And half of older patients with abdominal pain receive an abdominal CT scan. Meanwhile, 16% of patients receive an X-ray without an ultrasound or a CT as their sole diagnostic test. So X-rays have been shown to be a particularly ineffective diagnostic tool that can provide false reassurance to physicians. So the use of X-rays as the only diagnostic tool is particularly worrisome. As previously mentioned, the top cause of death for Medicare patients discharged from the emergency department is cardiac ischemia. Our study shows that this demographic is still less likely to receive an EKG as compared to another patient with a different chief complaint. These results suggest that there may be room for improvement in management practices. So the key takeaways are the triage trends between emergent classification, how severe the patient is considered versus the surgery rates, and those are misaligned. There's a diagnostic trend of overutilization of ineffective testing. So nearly 1 in 6 emergency department patients received only an X-ray for radiological evaluation. And there's seems to be a trend towards underutilization for effective testing. And we see that because a minority of older patients received an EKG. So overall, while there is a general recognition in emergency departments that older adults are at higher risk for significant disease, the optimal management of many disease processes has yet to be refined in order to better align the treatment goals of older adults and the care delivered in emergency departments. Thank you very much. For any additional questions, please scan the QR for our emails. Thank you.
Good afternoon. My name is Maura Kennedy. On behalf of my co-investigators, I'm pleased to present this abstract entitled Geriatric Emergency Department Accreditation, the first 2 years. We have no conflicts of interest to report. As the U.S. population ages, the healthcare system is increasingly challenged to provide high-quality care to older adults. Older adults proportionally have higher rates of ED utilization, often require more extensive evaluation in the emergency department, and may require more intensive care coordination if discharged. Geriatric EDs, or GEDs, were established in direct response to this growing population. The first described GED was established over a decade ago. However, there is significant heterogeneity among self-described GEDs. To address the variations in care processes of these early GEDs, in 2014, the Geriatric Emergency Department Guidelines were published. This is a consensus document of recommended care processes, staffing, and equipment for GEDs. Subsequently, in 2018, ACEP launched the Geriatric ED Accreditation Program, or JEDA, a voluntary accreditation program which accredits GEDs based on their adherence to the GED guidelines. The JEDA program has 3 levels of accreditation: Level 1, or Gold, the highest level of accreditation, Level 2, Silver, and level 3, bronze. As you can see from this table, increasing level of accreditation has greater requirements with respect to staffing, policies, outcome measurement, and equipment and environmental modifications. The primary objective of the study was to evaluate the reach and adoption of the JETA program in the United States. Our secondary objective was to compare level 1 and level 2 GEDs to level 3 GEDs based on ED characteristics and geographic considerations. We conducted a cross-sectional analysis of a cohort of GEDs that received accreditation in the first 2 years of the JETA program, namely between May 2018 and May 2020. We excluded GEDs outside of the United States as we used US classification systems to group geriatric EDs geographically. We also excluded GEDs from some aspects of the study when data use agreement restrictions precluded their inclusion. We identified accredited GEDs and JETA levels from the JETA database. Some covariates of interest were obtained directly from the JETA application, including ED visit volume and the proportion of ED volume that is by individuals 65 years of age and older. Other covariates, including data on ED length of stay, hospital 30-day readmission rates, US region, and urban versus rural designation, were extracted from publicly available data sources, including Hospital Compare. For the evaluation of key characteristics of GEDs by level, we merged level 1 and level 2 GEDs and compared these to level 3 GEDs. We made this decision a priori since requirements for level 1 and level 2 GEDs are much greater than level 3 GEDs. Over the first 2 years of the JETA program, 148 US GEDs were accredited, of which 10 were level 1, 11 were level 2, and 127 were level 3. This graph shows the cumulative number of accredited GEDs from May 2018 to May 2020, stratified by JETA level. 90% of level 1 GEDs were approved in the first year of the program, whereas 70% of level 3 GEDs were approved in the second year of the program. A greater proportion of level 3 GEDs received accreditation in year 2 of the program compared to level 1 and level 2 GEDs. For analysis of GEDs by level, 1 US GED was excluded from further analysis due to data use agreement restrictions. There was no statistically significant difference between level 1 and level 2 GEDs versus level 3 GEDs with respect to annual ED volume, proportion of ED visits that are by individuals 65 years of age or older, and 30-day readmission rates. Level 3 GEDs had shorter mean ED length of stay compared to level 1 and level 2 GEDs. Level 1 and level 2 GEDs were more likely to have an emergency medicine residency program compared to level 3 GEDs. There was also no statistically significant difference in distribution by US Census region, though close to half of level 1 and level 2 GEDs were located in the Northeast. Only 7 accredited GEDs were in rural regions, all of which were level 3, though this was not statistically significant. In summary, over the first 2 years of the JETA program, there was a rapid growth in accredited GEDs. The vast majority were level 3 GEDs, and a larger proportion of level 3 GEDs were accredited in year 2 compared to level 1 and level 2 GEDs. Most GEDs were located in metropolitan areas. Higher level GED status was associated with presence of an emergency medicine residency program. There are a number of limitations to the study, including the source of the data. In particular, some of our data was abstracted from the JETA application and could not be independently verified. The most significant limitation, though, is that the study was not able to look at the impact of JETA. Future research is needed to understand the impact of JETA on patient-oriented outcomes, as well as healthcare utilization and cost efficiency. Thank you. I'm happy to take any questions.
Hi, my name is Simon Yadger, and this is automated screening for cognitive impairment among older adults, an emergency department presentation using electronic health record data. This study was sponsored by the Shapiro Summer Research Program, as well as the Burby Walsh Department of Emergency Medicine at the University of Wisconsin School of Medicine and Public Health. Cognitive impairment is a state of impaired memory, judgment, comprehension, or behavior. It can be caused by a multitude of disease processes. Population-based studies have shown its prevalence to be high, particularly among older adults aged 50 or higher, with a prevalence as high as 15%. Cognitive impairment is common in emergency departments, particularly among older adults. Tools have been developed to quickly screen for cognitive impairment, one of which being the Blessed Orientation Memory Concentration Test, or BOMC. Despite recommendations to screen older adults for cognitive impairment, these tools are underused in emergency departments due to time and resource limitations. The purpose of this study was to evaluate whether machine learning algorithms can be used to identify older adults at high risk for cognitive impairment. We trained machine learning algorithms to predict whether a patient would score 10 or higher on a BOMC using patient variables present in the EMR at the time of admission. The data used came from an ongoing randomized control trial that enrolled ED patients at least 60 years old as they were discharged from the hospital. A total of 1,736 patients completed a survey that included a BOMC. We evaluated the performance of 6 regression or tree-based algorithms in predicting BOMC greater than or equal to 10. 48 predictor variables were used, which were primarily demographic or variables on comorbidities. All variables used would be present in a patient's electronic medical record at the time of arrival at the ED. Here is the complete modeling framework. To summarize, we used a nested cross-validation strategy, which allowed us to tune hyperparameters within our training sets, while still performing a 5-fold cross-validation to provide a robust, out-of-sample estimate of the performance of each algorithm. Area under a receiver operator curve was used as the primary metric of performance. The pooled receiver operator curves, as well as the AUCs for each algorithm, are shown here. The AUCs range from 0.68 to 0.73, with the XGBoost algorithm having the best performance. We see these algorithms fitting into the following emergency department workflow. An older adult presenting to the emergency department will be automatically screened by the algorithm for cognitive impairment based on variables already in their electronic medical record. Patients identified as high risk by the algorithm would then be evaluated for cognitive impairment with in-person screening, and patients identified as low risk would be evaluated for cognitive impairment based on clinical judgment. A similar framework is currently being evaluated using a fall prediction algorithm framework. To quantify our model's performance in a mid-sized emergency department, we calculated the performance of the XGBoost model on a hypothetical population of 200 older adults. A prevalence of cognitive impairment of 7% was assumed based on the prevalence in our dataset. Here, I show the hypothetical patients categorized as true positive, true negative, and false negative, based on the performance of the XGBoost algorithm. A total of 76 patients were classified as high risk by the algorithm and would undergo in-person screening for cognitive impairment. Compared to a framework that would require manually screening all 200 patients, this represents a 62% reduction in screening time. 4 of the 14 patients with cognitive impairment were identified by the algorithm as low risk, corresponding to a negative predictive value of 97%. In summary, we feel that the results of this study show that machine learning algorithms have the potential to assist in cognitive impairment detection in emergency departments by automating initial screening. This is a more feasible solution than screening all older adults presenting to the emergency department, and more robust than screening based on clinical suspicion alone. Future work should focus on training an algorithm on a more representative sample, using the complete electronic medical record as predictors, and evaluating real-world performance of automated screening. Thank you for listening to this presentation, and a special thanks to Brian Patterson, Colin Enstrom, Rebecca Green, Mark Craven, and Manish Shah for supporting this project.